Good morning, all. First of all, let me congratulate Agarwal Hospitals for conducting this wonderful CME and making me part of it. Today, we will be speaking about recalcitrant diabetic macular edema and the cytokine relays involved in it. So these are my disclosures. And as you know, diabetic macular edema is one of the leading causes of visual impairment and blindness throughout the world. And over the past 2 decades, the management of DME has been revolutionized by widespread use of multiple anti-VEGF agents as well as steroid implants. However, despite aggressive treatment, there are a subset of patients who continue to exhibit suboptimal response, who are called non-responders or recalcitrant macular edema. Definition of recalcitrant diabetic macular edema has been subject to a lot of controversies because some people look at visual acuity response, some others look at anatomical response, number of injections, etc., etc. Even in research, there has been a lot of difference. There are different authors who've looked at different definitions and methods to classify recalcitrants or non-responders. There are people who have used 350 micron with 3 injections, less than 15% reduction in central macular thickness, and persistence of edema after 4 injections, central macular thickness more than 300 microns, even lasting over 3 months after 3 injections, persistence or increase in subretinal fluid. So there are different definitions which have been put in. Anyway, there is a rationale for change in the drug or treatment modality in the case of recalcitrants, basically based on different molecular target or tachyphile access to some drugs, humoral responses to some anti-VEGF agents which may occur because we are using murine antibodies, and additional anatomic and functional damage because of laser photocoagulation. We all know that VEGF has been the major player, and it actually promotes metalloproteinases, increases fenestrations in microvascular endothelium, and upregulate leukocyte adhesion. So inhibition of VEGF activity has been the major target. We did a study to look at how the VEGF levels are varying in response to clinical treatment with ranibizumab, and to identify and characterize the responders and non-responders to anti-VEGF therapy. So we had patients with diabetic macular edema. We had 40 patients who had 6 months of treatment. The 1, 2, 3, and 6 months injections were mandatory. Injections in month 4 and 5 were administered according to PR and protocol. If the edema was more than 300 microns, we would inject, otherwise we would not inject. We had looked at visual acuity and OCT as well as VEGF and cytokine levels. My criteria for categorizing responders from non-responders were that macular thickness reduced to more than 40% in the first 3 months. Macular thickness had normalized in the first 3 months of mandatory injections, or only if the 4 mandatory injections were required in total of 6 months. If all 3 were to be present, then they were labeled good responders, and all 3 were not there, then they were labeled as non-responders. So it was not a central cut. It's just basically grouping a group on the responder side as compared to a group in the non-responder side on 2 sides of the spectrum. We acquired and stored these samples in -70 degrees before we did this. This is the VEGF levels at different time points. It was started with about 900 units, which dropped down to the first injection. And you can see that 1, 2, 3 injections were mandatory, and you can see the significant reduction in VEGF. By the 4th and the 5th month, actually, the patients who had recalcitrant or non-responder group, they were the patients who got the injection. And the 6th injection was mandatory, and that is where this was taken. So you can see that after 3 injections of continuous drop in VEGF, there was a slight increase. This is the overall VEGF drop, which is significant. Visual acuity, this is the Logmar visual acuity score, which actually showed an improvement. And this is the total visual acuity, as was in central macular thickness. You can see that it showed an improvement. Now, this is a very interesting slide, which shows the change in VEGF, visual acuity, and central macular thickness in responders versus non-responders. Here you can understand that the responders are in the blue and non-responders are in the red. You can see that the visual acuity, the responder visual acuity was poorer. And as we treated, you can see that the visual acuity in the responder group significantly improved, because this is log bar reduction of the graph is improvement. And the red, the non-responders, showed significant worsening. Similar was the case of central macular thickness. The blue, you can see that it's reducing, whereas the red, which is the non-responder, is staying there. Looking at the VEGF, it is very interesting to know that it was almost equal to start with. After the first 3 injections, it reduced significantly in both the groups. Then you had to inject only the non-responder group, not the responder group. That's why these two have only the red. And when we take the mandatory 6th injection, you can see that the responder group had more VEGF levels than the non-responder group, which tells us that the non-response is not because of non-VEGF reduction, but some other players. Now, I group the VEGF levels into 150 to 600, 600 to 1,750, and more than 1,750. These were the results. You can see the very high VEGF group had a different graph altogether as compared to the other 2 graphs. So you can see that it was very high. It fell down also, but as soon as the 3rd injection was over, you can see that it significantly increased. The central macular thickness also showed an interesting result in that the high VEGF group, which is the green, actually fell down in central macular thickness over the other groups, signifying a central macular atrophy. The visual acuity of that group also was very poor, in the sense the other 2 worms are almost together. You can see that the very high VEGF group had a much poorer visual acuity throughout the study. Now, looking at some of the other players, including interleukin-6, you can see that the IL-6 at baseline itself was very high. And you can see at 6th month injection, you can see that the IL-6 is much higher than the responders, much higher than responders in the non-responders. IL-8, you can see that the IL-8 is significantly high even with treatment. IP-10 was also showing a decreasing trend in responders, whereas an increasing trend in the non-responders. MCP-1 was keeping on very high in the non-responder group as compared to the responder group. So it is almost double. This is the 2D gel electrophoresis of responders and non-responders pooled AQUEOUS. And you can see that these boxes show the difference in proteins between the. The findings are that the VEGF is reduced in both responders and non-responders. Non-response is not linked to VEGF levels. A small subgroup of patients, though, exist with very high levels of VEGF, which behave completely differently. Other cytokines, including IL-6, IL-8, and MCP-1, play a major role. So reasons for variability to the response are not completely understood. VEGF polymorphisms may be the reason, and there may be a need for alternate signaling mechanisms and protein candidates. And inflammatory cascades should be using cytokines and chemokines, which should be monitored. And studies should be conducted to evaluate the prognosis of patients with DME by monitoring cytokine levels. Thank you very much for your kind attention.